So first of all, hello to everyone and welcome to this breakout session on CLL and SLL. My name is Sabina. I'm a longtime supporter and volunteer of Lymphoma Canada, and I sit as the vice chair of the board at Lymphoma Canada as well. I'm pleased to welcome today our expert, Dr. Lin Yang, to answer your questions from the breakout session earlier today on CLL and SLL. As a reminder to our audience members, you are welcome to submit your questions into the question and answer, the Q&A box. It's basically in the black bar at the bottom of your screen. You should see a chat icon box. It's called Q&A. If you type in your questions over there, we can take your questions as many questions as we possibly can fit in our half-hour session today. So please take the time and add in your questions in the Q&A box. We're going to start with a couple of questions that were submitted to us earlier on. So I think the first question, Dr. Yang, that we hear very often, from some of our audience is that, what does it mean about CLL being a chronic cancer? Very often we have, patients asking us, does it mean that we will never be cured? And, on the flip side, what is the goal of treatment with CLL?
Thank you, Sabrina, for that excellent question, and welcome everyone. It's my pleasure to join you for the Q&A today. That's a big question. I'll try to tackle it in each of the sections on its own. So to call it chronic, it means that it tends to brew slowly over time. It starts at some point and then it just slowly builds over years. And opposed to acute is something that starts and goes very quickly, usually within weeks or short months, things build up. This is the opposite. This is something that's very short and slow, and then it creeps up over time. And it does tend to mean it's less likely to be curative. When we're dealing with these kind of chronic leukemias, chronic lymphomas, there's less of a chance that we can get rid of it altogether. So what a typical treatment pattern would look like if someone even need treatment is that the disease will build up and the burden will start causing some symptoms. We treat, we get rid of the detectable disease, but over time it will build up again. So therefore, the goal of treatment is to have maximum benefit to get rid of the disease burden without costing too much in terms of side effects, because in years to come, the disease will build up again. So it's about gentler treatments, more tolerable treatment with maximum benefit. And we're seeing a lot of that within immune targeted therapies. This is opposed to acute kind of cancer where you tend to hit it really hard and really quick at the beginning to try to get rid of it. So I hope I tackled all the aspects of that question.
That's, and actually that takes us into some of the follow-up questions. We have received a couple of questions on therapies. And so, one of the questions that people very often ask is, why was my treatment option only wait and watch, and why not chemotherapy like some of the other lymphoma patients receive? And the flip side to that also is, what symptoms should I look out for? What symptoms should I go back to my doctor to speak about that would make me move from the watch and wait to an active treatment phase? So I was wondering perhaps if you could tackle some of the watch and wait questions that we get very often as well.
Yeah, I get this all the time in the clinic because, people come to me and say, well, you've diagnosed me with a cancer. Why can't you get rid of it right there and then? The answer comes down to 2 to 3 aspects. One is, as we talked about, is a chronic condition, so it builds up slowly over time. And when we kind of reflect on the last 30 to 50 years, knowing the history of CLL, we can see that actually about 50% of our patients, perhaps even a little bit more, never require treatment in their lifetime because it's building so slowly, it doesn't really impact them. And we know for the most part, we can't cure it. So if it's not impacting you and we can't get rid of it, we think that to treat at that time, at the time of diagnosis, you're not getting much benefit because with the treatment, yes, we can get the CLL cells down and undetectable, but that's not going to make you feel any better because you already feel fine. You're not impacted by the CLL. And if you are one of those that are never really going to require treatment in your lifetime, why take therapy and why take the risk of the side effects? So that's kind of the big principle behind this observation period and not having to treat right off the bat. During the observation period, it's not like we're just going to leave you alone. We are going to check on you. We're going to follow along. Um, you know, the problem is at the time of diagnosis, we can't really predict with great accuracy who are the ones that are going to need treatment, who are the ones that are not. So we tend to follow everybody kind of on this schedule, and things may declare itself. And the things we watch out for to know that, okay, it's time to need treatment is really mostly the most important is how you're feeling. If you're feeling tired that you can't explain otherwise, if you have enlarging glands that are painful or growing quite large, that would be indication for treatment. If you are losing lots of weight that you can't explain, you have drenching night sweats, those are all part of when the CLL cells or burden is increasing enough that we think, okay, now it's time to try to get rid of it so we can now make you feel better. There are some changes in the blood work. So sometimes people are feeling absolutely fine. And what we pick up in the blood work is that your CLL cells, now this is not SLL, this would be CLL because we can pick it up in the blood. You can see that the cancer cells are growing very quickly. So quickly means that the lymphocyte is doubling every 6 months or less. Or we may notice your other blood counts are starting to drop because the cancer cells are accumulating, is taking up space in the bone marrow. So your normal blood making cells are starting to run out of space and they're not doing their job. So sometimes it could just be blood work. So that's why it's important to see your doctor even during the active observation period for physical exam, for blood tests, because we're monitoring the burden of the disease. Now, when should you call your doctor in between visits and say, okay, I'm having some trouble. I'm worried about my disease? Well, if you have any of those symptoms that I talked about and is coming on in between appointments, drenching night sweats, weight loss, really, really tired that you can't get through your day, or you're noticing your glands are growing really quickly. It's supposed to be very slow. You may not even notice the change, honestly, from months to months. But if you're noticing that, oh my goodness, it was like an almond size a month ago, and now it's like, a grape size, and now that's a sign that things are changing and your doctor needs to know about that. So that's what you can do to observe on your side. And then when you visit the doctor, they will do the physical exam and blood work to monitor the chronic side.
And I think you bring up a really great point about when to speak to your doctor. And I know one of the questions we've been hearing a lot now that we're in the last 2.5 to 3 years of the COVID pandemic, follow-up care for CLL has been, lessened significantly. And so one of the questions we've received from the audience was, during COVID, my follow-up care for CLL, for which I finished treatment 4 years ago, has lessened. I worry about not catching a relapse until it is too late. Do I need to start a conversation with my family doctor or with my hematologist to begin having these regular follow-ups again?
Yes, I think it's very important to have that conversation. When we talk about treatment, and it sounds like you're on a fixed duration treatment, the longer you go from that, um, the better the chances, right? The disease hasn't come back. So that's a good sign. But we know it's for the most part non-curative. So there is a chance that it will start picking up. So you're right. You need to re-engage with your doctors to start doing blood checks and physical exams. And unfortunately, that's just, pandemic kind of hit us all worldwide. And I had to convert a lot of my assessments to phone calls and blood works, but we're starting to get everyone back in their normal pace. But be assured that if you're feeling well and you're getting your blood checked, they will pick up relapses if the disease came back.
That's a great point. And I think, I'm just going to go through a question that we've received sticking on basically regular testing. Another question we've received is, are there certain tests our physicians should be carrying out to detect second cancers that you mentioned in the breakout session, or would it just be the regular blood work, being aware of abnormalities in our body?
Yes, that's a very good question, because in my talk, I talk about how people with CLL, their immune system, the barrier is a bit weakened, like the sieve that's got some holes in it. So other cancers do come through, and we're very vigilant in our clinic to screen them. And just don't forget about skin cancer. That's my little plug. People think about breast and lung and prostate and colon cancer, but also think about skin cancer. So the way that we recommend screening for it is really to do your follow your provincial guidelines. Every province has their own set of guidelines as how often a mammogram should be done, at what age, and colonoscopies and prostate checks. Just get them done. So just don't gloss over, and just make sure you do it. You don't have to go above and beyond that, because that's meant to pick up cancers. So just do it. From our end in the clinic, I've picked up some cancers, and how we do it, that's kind of come through is a couple of ways. One is their blood work will show abnormalities, but it wouldn't be CLL related abnormalities. So to give you an example, someone's got very chronic, very slow growing CLL, and then all of a sudden they're very anemic, which means their hemoglobin dropped, and that's discordant, that wouldn't fit. So then I work someone up for the anemia, and I find they're low in iron. And the number one thing we got to do in people who are over the age of 50, low iron, is to do a colonoscopy. So I've picked up some colon cancers that way. I've also picked up some other cancers just by the exam. The glands on a CLL patient feels one way, but a gland of like breast cancer or a lung cancer feels differently. So I've picked up cancers that way. So on one hand, you do your part to follow the provincial guidelines, but on the other hand, when you're seeing your doctor and doing that exam and blood work, we can also pick it up, but that's far less common. It's way better to do the provincial guidelines and follow the rules.
That's actually, I learned something new over here as well. So thank you for that clarification. So it's good to know that you follow your provincial guidelines as well on the other testing. Thank you for that. We're going to stick with testing. We're going to stick with therapies as well. Another question that's come up is, how long can ibrutinib work? I understand some people stop due to side effects, or it stops working. And so we'll start with that. And then I think we have a couple more questions on therapies and side effects as well.
Okay, that's a great question. Ibrutinib was the very first targeted agent that we had available, and it revolutionized treatment and improved outcome in many, many patients. It was a great drug. There was a 8-year update of ibrutinib from the very first study that published its benefit. So when these trials are being approved, what they have to do is what's called a clinical trial, where they take a drug, take half the people on it, half the people not on it, and they compare outcomes. So that's how ibrutinib got approved, because that very original study showed benefit. We have now the 8-year update from that very first study. And what it shows is that ibrutinib continues to be a very good drug. It shows that on average, people are staying on the drug between 4 to 5 years. And in that 4 to 5 years, they have no, I'm going to try to phrase it so that it's not so statistically technical. Try to phrase it in a more kind of lay terms. So when they do a study like this, they look at what's the average time of response. Can I say that with the ibrutinib, it actually hasn't in that 8 years, it has not been reached. So for people who can stay on ibrutinib up to 8 years, they are still doing very well. 50% of the people, more than 50% of the people are still having excellent benefit. Whoever asked this question is very, very intelligent, because they brought up the fact of drug discontinuation. So yes, ibrutinib being the very first drug, it has some off-target effects. So it affects BTK, which it was designed for, but there are some other proteins in the body it's affecting. So it's not as specific. So we're starting to see some side effects. So at the 8-year mark, about 40% of people still stayed on the drug. And many of these people came off the drug because of side effects. So really what this drug is telling us is if you end up staying on it and you can, tolerate it, your outcome is excellent. But there are that group of people who can't tolerate it for a variety of reasons. But thankfully, since the ibrutinib discovery, we now have other drugs that are more specific to the BTK inhibitor, and we're seeing less side effects. So acalabrutinib, and in our province, we're getting access to zanubrutinib. These are all drugs of the same class. And there's a new drug that's being studied now, yet a fourth one in that family. So we'll have a plethora of drugs to kind of pick from, and you'll work with your doctor to figure out which one is the right one for you, but all of them are excellent in terms of long-term benefit.
Hearing about all these new therapies makes me really, really happy and really excited as well.
Yeah.
And sticking with the theme on side effects, one of the questions that we get very often is, why do some lymphoma patients experience adverse effects, from monoclonal antibodies? And are these side effects common to all monoclonal therapies or just a few of them?
So monoclonal therapies are excellent. They've been around for a really, really long time, since 1997 with the start of a drug called rituximab. And now we have obinutuzumab, which is the two monoclonals that we use in CLL treatment. It complements chemotherapy if you're going to use it in combination with that. It complements targeted therapies if you're going to use it with that. So it's a good synergistic drug. There's not much side effect to like long-term side effect to these monoclonal antibodies, but there's two main ones. One is an infusion reaction. So when you first get it, there's a potential that your body could have an allergic type of reaction. In CLL, that's actually quite common. And that's because obinutuzumab is very effective. The minute it's starting to go into your body, it's starting to hit those CLL cells and getting rid of it. So the reaction you're having is actually like the body's reaction to the cancer cells dying. So that is not particularly person specific, it's the disease. If the greater the burden of your CLL, the more likely you're going to have a reaction to obinutuzumab when you have that infusion. And we recently studied this, and we saw that people with lymphocyte count or WBCs over 100 had the greatest risk of developing reaction, just because there's so much CLL cells that the monoclonal antibody is hitting. The other side effect of obinutuzumab is the infection risk, because it's hitting one of the major proteins that help fight infections. So you could see more like it's a lot of like lung type infections, sinus type infections. That one is less common, and I think that one is more person specific. If you're already prone to a lot of these sinus infections in your life, having obinutuzumab or rituximab on top of that, you're likely to see that. But if you're not prone to have that in your life, you're less likely to see that. So the one side effect is related to disease, one side effect is related to the person.
One of the questions that we get very often, and frankly, I've actually received this question at every Lymphoma Canada panel I have done, and it's such a common question, is speaking on therapies again, before I consider a secondary treatment for my relapsed CLL, is it okay to ask for a second opinion? I think the question on second opinions comes up so often, and very often, people are simply not aware about what their options are. And so would love if you could speak to that a little as well.
Absolutely. It's a very simple answer. Yes. Get as many opinions as you are comfortable. CLL management is very diverse. There's so many options. And, this is your treatment, and you're taking the treatment, and and also the side effects potentially. So you need to be comfortable with the options that are presented to you and get as many opinions as you need. To us as physicians, we want to help you. So if you feel that you need more opinions, go and get them. It doesn't like we don't take personal issues with that. If you ask me for second opinion, I will refer you to my colleague right away because this is important for you. I do have to say across Canada, depending on which province you're in, the funding for treatment for CLL is a little bit different. We have the same backbone, but there are some nuances where one will be different than the other, and doesn't mean one is better than the other. It's just that there's slight differences in practice between provinces. So if you're going second opinion to a different province, you may get a slightly different opinion back. But if you're sticking to the same center, you're likely, because everybody's functioning under the same umbrella, you'll get the same access. But if you're going cross provinces, just be aware that some of the options are not always available in every province.
Good reminder with the provincial differences for sure. We have a technical question from the audience, and one of our audience members would like you to explain what a P17 deletion means.
Yes, so I'm just going to clarify that when you mean P17, you're actually got two different entities here. So one is deletion 17 and one is P53. So I'm going to separate them two and talk about it, and then we'll come back and put them together. So one of a major defense mechanism against cancer. So our body has these mechanisms in place to prevent cancer from growing. And one of the strongest anti-cancer mechanism we have is this P53 protein. So you can think of it as a very strong gate. Cancer cells are trying to get in, and P53 is a major gate, and it keeps the cancer cells away. It's very, very powerful. But if you start losing that function of P53, it doesn't work anymore. That gate is wide open. So cancer cells escape and get into the body. So this P53 is not specific to CLL. You'll see it in a variety of other lymphomas, mantle cell, marginal zone, all sorts of other lymphomas, because it's a major cancer gene. It's not specific to CLL. But when it does come to CLL, like many other cancers, it is also very important. And so when we start seeing defect in this protein is when we can potentially see an aggressive CLL come through. And we know that people who have defective P53 protein, that they will run into trouble. And we know that their outcome is much improved if you use targeted therapy over chemotherapy. So you'll hardly ever, I can't imagine any situation where a doctor will ever recommend chemotherapy if you have a P53 defect. So how do we measure this P53 defect? How do we know you have it? We take your cancer cells, your CLL cells, and we do two tests. One is we do a chromosome test. We know the P53 gene comes from a chromosome 17, chromosome number 17 in your cells. You have 23 chromosomes from mom and dad. So on chromosome number 17, there's a tiny little spot where the P53 is being made. We can actually see if that chromosome 17 is still intact, or is it missing? Because that's what deletion 17p means. That 17 chromosome is deleted. So you have lost P53. The other way we check it is we actually sequence, we do genetic testing, and we can find this P53 gene and make sure it's intact. So it's very labor intensive, and we have two complementary ways to check it. And if at any point you either have lost the chromosome 17 or you have a mutation in the gene itself, now you have CLL with a p53 mutation, and if you need treatment, because you could still live a long time, live without needing treatment, but when you do need treatment, we would be offering targeted therapy in those patients.
Thank you so much for that very, very thorough explanation. I think we only have time for one last question. Unfortunately, this half an hour has completely flown past. And so this is another question that we get fairly often as well. What clinical trials are currently underway for CLL patients, and how do I get involved in these?
Oh, great question. So clinical trials, I strongly encourage clinical trial enrollment if there was one available to you and you were eligible. And that's because you get access to new therapies, it advances the field. This is how we know how drugs work. The thing about clinical trials is not really standardized across Canada. What really happens is a company, usually a company, will come up with a new drug in which is undergone really rigorous testing. So we know it's safe, we know the dose to use, and now they want to test it in CLL patients, kind of that final step. So the companies will typically approach individual cancer centers to see if, were you willing to participate? Do you want to participate? And the individual cancer center decides if they want to participate in this trial. So that's why every province is going to vary. In our province in Manitoba, we have 2 CLL type of trials happening right now, but that's not necessarily across the rest of Canada. It all depends on what the center is doing and whatnot. So usually the doctor that treats you, your cancer doctor, will know about these trials. So if you need a treatment and they knew this trial was open in their center, they often will approach you and tell you about it and share information. So that's how you're going to get enrolled. In the US, very different story. So if you want to get into a clinical trial in the US, logistically, there's some financial stuff, there's some travel stuff. It's a little bit harder to get into a trial in the US, but there are some public trials in the US in which you could be eligible for, but explore that with your cancer doctor.
Amazing. Thank you so much for answering all of our questions today. I know we didn't get through everyone's questions, so if you have an outstanding question, please feel free to email us at info@lymphoma.ca, and we'll try our best to actually get back to you with a response to your questions. And I'd like to conclude this session by thanking you, Dr. Yang, so very much for sharing your expertise, your knowledge, your time with us today, participating in today's conferences, the sessions as well. So thank you so much from all of Lymphoma Canada for everything that you've shared with us today. We also hope that those watching today learned something new about their or their loved one's lymphoma subtype. So thank you, Dr. Yang, for being here and answering all of our questions.
Oh, it's my absolute pleasure. It's great. Thank you so much for doing this.
Amazing. Thank you once again. And so for those still here, please tune in to the closing remarks in the auditorium. It's going to be starting, in fact, right now. So please join us in the closing remarks, and thank you again for joining us today's session. Good evening.